Hi guys, Dr. Gillard here. This is the Endocrinology lecture for Thursday, week 5, fall 2021. Doing this one from home, not feeling the greatest today. So here we go. Where have we been? So last time we talked about hypernatremia, or salty blood I like to call it, too much sodium versus water in the blood. And we said that that will trigger both directly and indirectly the release of antidiuretic hormone from our friends the magnocellular neurons. We talked about the CVO mechanism and how that was an indirect mechanism that triggered magnocellular neurons to release ADH. And we talked about the magnocellular neurons themselves could also directly sense hypernatremia, and which in turn causes the release of ADH. Quite an interesting setup. And here again is that circumventricular organ, or the CVO, which is in the third ventricle, roughly in the wall of the third ventricle. And it does have some connection with arterioles and capillaries that it samples for sodium content, very much like the macula densa cells. And if it senses an increase in sodium, if it senses the increased sodium ion, that triggers an action potential which goes to magnocellular neurons and the supraoptic nuclei mainly, and that triggers the manufacturing and release of antidiuretic hormone. Okay, and yeah, the rest of that's review. Also, ADH, of course, binds to principal cells of the glomerulus, or binds to principal cells of the kidney, and it causes the reabsorption of free water, but not sodium. That's a very important point. And this process accomplishes two things. It fixes the hypernatremia by bringing in free water. If you have too many sodium molecules, you need to bring in water molecules to offset that. And then the volume of water coming in will also raise the blood pressure. All right, so what if something goes wrong with ADH? What if it's not made properly? What if it stops being released from the hypothalamus? Or what if the kidney starts becoming resistant to it? What if it can't bind? Well, then we get a condition called diabetes insipidus. But if that occurs, if you can't reabsorb free water from the filtrate, you get hypernatremia, you get hypotension, could occur, hypernatremia could occur, polydipsia will occur, you'll be super thirsty, and polyuria will occur as well. Even if you don't have access to water, you're still going to be urinating quite a bit, because you can't absorb free water. And if you're drinking 10 liters of water a day, you're really going to be urinating. That's polydipsia. What could go wrong with ADH? Well, as I said, magnocellular neurons may become dysfunctional. Maybe they've become mutated somehow. Maybe there is a cancer growing in the hypothalamus that's mutating the supraoptic nuclei, or maybe they just get inflamed and quit producing ADH. So it could be a problem with magnocellular neurons. Sometimes there's nothing wrong with magnocellular neurons, but the problem is with the principal cell, like the V2 receptors won't bind ADH properly. Or maybe it binds ADH okay, but then it has to make aquaporins too. Maybe something's messed up with that central dogma of aquaporins too. But anytime ADH is not doing its job, the condition is called diabetes insipidus. There's a rare exception to that rule we'll look at, where you just overdrink water, but that's super rare. How does it typically present? So those affected will be urinating all the time. officially, it has to be more than 3 liters a day, or at least 3 or more liters a day. Normally, it's around 10 liters per day of urine, and it can be up to 20 liters of urine per day. That's urinating probably every hour and a half. It's constantly urinating. So, but on average, it's about 10 liters a day. And again, that's called polyuria. Some authors call that diuresis. It's the same thing as urinating all the time. Polyuria, diuresis. And so those affected also have polydipsia, as we said already. They have an urge to constantly drink water. And as we said before, that water can offset the deadly hypernatremia and fix the hypotension as well. How does the patient typically present? Part 2. Well, if you do a urinalysis, in fact, this is an easy way to catch this. If you do a urinalysis, they're going to have a salt, poor, water-rich urine. In other words, it's going to be hypertonic. The urine is hypotonic. Hypo means not enough salt. So it's a water-rich urine, hypotonic urine. Right? You could also say that the urine fails to concentrate. Yeah, because if it concentrated, it would get more and more sodium within it. Hypotonic means there's too much water in it. The water molecules to sodium molecules. Too much water, not enough sodium. And we said that these patients present with polydipsia. Patients typically are able to drink enough water to compensate for the hypernatremia. We'll look at what happens when they don't. So all of this water that they drink kind of drives or helps drive the amount of polyuria. Right? So normally when they present in the clinic, they'll have normonatremia. Normal means normal. Natri means sodium. Anemia means blood. So they have normal ratio of sodium to water in their blood. And they could have a mild hypernatremia. So that's how they usually present. Maybe just a touch of hypernatremia. Oftentimes they're completely normal. What about diabetes insipidus versus diabetes mellitus? What's the story with that? Well, insipidus means tasteless. And if you tasted their urine, because of all that water, it would taste pretty much like water. The water content would be so high. Diabetes, of course, they have uncontrolled high blood sugar, and a lot of those glucose molecules spill into the filtrate and into the urine, so you get a lot of glucose in the urine. If you tasted or even smelled that urine, it smells sweet or it tastes sweet. So that's one way. I guess they used to do things like that back in the day. We certainly don't have to do that anymore, though. What if it's impossible for them to get hold of water? What if they're out in the desert with these camels and they can't get water? What happens then? That is really bad. They'll have full-blown hypernatremia at that point, and they will develop hypotension from the lack of absorption of free water. Hypotension always goes along with tachycardia to try to make up for the low blood pressure. The heart will beat faster. Could have put tachypnea. Authors never include tachypnea, rapid breathing, but those two go together as well. And they're going to be dehydrated as well. Right? Moderate to severe. So what are the symptoms of moderate to severe hypernatremia in this situation? Or maybe they just have they've completely lost ADH and they are drinking water. They still could occasionally get moderate to severe hypernatremic symptoms. They develop classically something called orthostatic hypotension. We'll look at that just in a minute here, but it's basically when you stand up from a supine position, you get very dizzy and could even pass out. So orthostatic hypotension is from low blood pressure, hypotension, which is from urinating all the water out of your body and not being able to reabsorb the free water. In fact, you guys know how I love these most common findings. That's the most common finding. They're going to be dehydrated, so they'll have abnormal skin turgor, which is a weird word. If you pinch the back of your skin underneath your clavicle, if you can pinch it and let it go, it bounces right back to normal. If you don't have enough water around and you're dehydrating and you do that, it stays bunched up. That's an abnormal skin turgor, which is positive for dehydration and probably hypovolemia. And they'll have tachycardia because of the low blood pressure. They could, if it's severe toward the end of the disease's course, before death occurs, you could get something very scary called hypertonic encephalopathy. At this point, if your blood is so salty and needs water so badly, your body will start pulling it out of the cells and out of the interstitium. That includes brain cells. And it's not a good thing to pull water out of brain cells because it kills them. We'll come back to that. Let's look at orthostatic hypotension again. Again, it occurs when the patient is supine, you take their blood pressure, and then you have them rise quickly into a standing position. You wait 3 minutes, I could have added in there. Wait 3 minutes and retake their blood pressure in the standing position. Be careful they don't fall. Have an assistant ready to catch them if they fall. If the blood pressure is decreased by 20 millimeters of mercury or more in this supine position, they have orthostatic hypotension. If systole is decreased, or if diastole is decreased by more than 10 or more, that makes the diagnosis of orthostatic hypotension as well. Okay, so what's the story with this? There's many. You're not going to like it. You're not going to like orthostatic hypotension because there's many causes of it, and we'll list some of them here in a second. But basically, it occurs because the carotid sinus, the nerve of Herring and cranial nerve 9, for whatever reason, or the tiger cage itself, that mechanism is broken of sensing decreased blood pressure. We said normally that when you get a decrease in blood pressure, that decreases the rate of firing of the carotid sinus, the receptors in the carotid sinus, which is the nerve of Herring receptors. And that decreases the flow of action potentials to the tiger cage gate, or to the vasomotor center, really. And that lets more sympathetic output come out of the vasomotor center, and that immediately boosts your blood pressure. Well, what if your nerves are damaged? What if you have diabetes and your nerves don't work very good? Well, that mechanism is going to be delayed or maybe completely broken. And so you can stand up fast and you can be dizzy for hours with this problem. So the patient suffers dizziness, syncope, near syncope, pre-syncope, the same thing. And it tends to be worse after eating a large meal and after exercising. It can set it off. It doesn't have to be always rising from a supine position. And I know, I hear you grumbling, but it is what it is. These are the things that can cause orthostatic hypotension. Let's look at the key ones for sure. Know the red ones, and for sure know the red ones with stars. It could be a sign of Parkinson's disease, which destroys the autonomic nervous system. So the sympathetic outflow would be broken and wouldn't be able to correct that message of hypotension. Diabetic neuropathy and other types of neuropathy destroy the nerve of Herring and the cranial nerves and cranial nerve 9, and so you can't get that signal to let more sympathetic outflow go. Alcohol-induced neuropathy, Guillain-Barré syndrome, Addison's disease, hyperaldosteronism. If there's too much aldosterone, you reabsorb too much salt and water. We know that mechanism already. That's wrong. It should be hypoaldosteronism. not hyperaldosteronism, because anything that causes hypotension can do this. And hypoaldosteronism, so make that correction there on slide whatever that is, 13. Diabetes insipidus is what we're talking about. Anything that causes severe hypotension, as we said. Chronic diarrhea, cardiomyopathy, severe tachyarrhythmias, especially with the ventricle, myocardial infarction. Drugs can cause this. Definitely, these are, you need to know these. If a patient complains of getting really dizzy when they get up and they're on nitrostat for angina, for chest pain, and they take nitrates, that could be causing this orthostatic hypotension. Or Parkinson's. Ironically, the treatment for Parkinson's disease also makes the orthostatic hypotension worse. Tricyclic antidepressants, some docs prescribe those still for chronic sciatica. You'll see those. Sildenafil or Viagra can also do that. Alcohol, lithium, for bipolar and other psychological disorders can do the trick as well. So there's a lot of causes. Sometimes it's just best to try to figure them out. Like anything that causes hypotension could cause orthostatic hypotension. You just got to, and anything that damages, especially sympathetic nerves, can cause orthostatic hypotension. All right, let's go back to this hypertonic encephalopathy again. So hypertonic again means, hypertonic means too much sodium. So that's the cause of the encephalopathy. That's that problem with the brain. And basically it's severe hypernatremia, as we said already, that causes the cells of the brain to lose water. They shrink and they start short-circuiting and causing all kinds of brain problems. Okay, so if the only place, as I've already said, if the only place left to get free water is the brain, well, it'll take it from, it'll take it. You have to get that sodium, that concentration of sodium water has to be fixed. You have to dilute that sodium in the blood, or you're going to die. But this is not the greatest way to do it, but it will do it. It'll suck water out of the interstitial fluid around the brain cells, and it'll suck interstitial fluid right out of the brain cells themselves. Okay, they physically shrink, and they die. And they cause all sorts of dysfunction as they die. And the brain can literally shrink in size because of this. What are the symptoms of this shrinking? And not only the brain, but the endothelial cells of the blood vessels of the brain can start to shrink and die and let blood flow into them. And you can get subarachnoid hemorrhage from this condition. Hyperreflexia, you can get all kinds of weird positive neurological findings. Seizures, coma, death, altered sensory function, lethargy. So not a good thing, this hypertonic encephalopathy. What else can cause hypernatremia? Well, any loss of body water. We talked about dehydration. We talked about diarrhea, how you lose more water than salt. So if you lose more water than salt, you become hypernatremic. Diabetes mellitus. This is an interesting, I do like the test on this one. So diabetes, you have mellitus, you have too much glucose floating around in the blood all the time. Some of that gets into the filtrate and can't be reabsorbed. But it's almost like sodium and water's relationship. Glucose is very polar, a very polar creature, and very hydrophilic, loves water to hang on to it. And if the glucose molecule goes into the filtrate, a bunch of water is hanging on to it. It gets sucked into the filtrate as well. And it hangs on to glucose and can't be returned. And so you do lose water because of that and become dehydrated. And if you become dehydrated, you become hypernatremic. Chronic kidney disease, where you can't clear the sodium out of the blood, can also do the trick. But let's get into the different types of diabetes insipidus. There's 3 types. There's central diabetes insipidus, Nephrogenic diabetes insipidus. I almost didn't put this one in because it's so rare, but there's one called Dipsogenic diabetes insipidus. That's the one where something's wrong with you. You have mental disease, or you have a tumor in the thirst centers of the brain, or you went on a radio game show or some challenge and you drank 5 gallons of water and died. This is from drinking too much water. So I don't like to really include it in diabetes insipidus, but yet you might see it in there. Let's talk about central first. A bunch of AKAs again. Hypothalamic diabetes insipidus. I don't think they're going to use that one because that tells you the cause of it. Neurogenic diabetes insipidus, meaning brain. Cranial diabetes insipidus. Guyton, which is a board book, uses central, and I think this is what's going to be on the boards. Central diabetes insipidus. What's the cause of this one? This means antidiuretic hormone is not being released from the pituitary, period, end of sentence. By far the most common cause of diabetes insipidus is something went wrong with magnocellular neurons. Got it? And so what could go wrong with magnocellular neurons? Well, maybe you had a prolactinoma, which is the most common tumor of the pituitary gland. It's a tumor in the anterior pituitary that secretes prolactin. Maybe you had surgery for that, and it ended up damaging the axons. Remember, the axons come down from the hypothalamus down to the posterior pituitary to release ADH. And maybe the surgery damaged those neurons on the way down. And that by far is the most common cause. 73% of the time, diabetes insipidus occurs after pituitary gland surgery. 9% of the time it's from an autoimmune disease, where from smoking or from whatever reason the cells of the magnocellular neurons, some genes get turned on that aren't supposed to be on, and it gives the magnocellular neurons a different phenotype, a different look. And the body's immune system all of a sudden doesn't recognize them, and it says, you're alien, let's attack you. And they get destroyed, and you can't make ADH. Could be that same prolactinoma may grow and grow and grow and pinch the axons running down from the hypothalamus to the posterior pituitary. That could do the trick. It's rare, but there are gene mutations where the magnocellular neurons can't make ADH, or the ADH it makes is not folded properly, and it has trouble binding to the principal cells. So those are congenital mutations, and sometimes it happens and we don't know why it happens. It's probably some weird virus, some weird inflammation that occurred. But again, central means there's something wrong with ADH. How do they present clinically? Well, pretty much the same like a broken record. Polyuria, nocturia, that just means they're peeing at night, they're peeing in the day. Polydipsia, they're thirsty all the time. They have to have at least 3 liters of a urine catch of at least 3 liters a day. It'll be more than that, probably 10, we said. When you take their blood serum levels of ADH, they're going to be low. That's an important clue. That's going to differentiate it from the next type we're going to talk about. Again, they typically have normal natremia or very slightly elevated blood sodium levels or slight hypernatremia. And that's true as long as the thirst centers are properly working and they have access to water. The next type of diabetes insipidus is called nephrogenic diabetes insipidus, and that gives it away. The problem in the nephron. And it occurs when the kidney becomes resistant, meaning it won't bind to antidiuretic hormone. Or there's another problem as well. Maybe it binds okay, but you can't make aquaporin's 2 channels. So mutated ADH V2 receptors could do the trick. Or or some mutation where you can't make aquaporins 2 channels. That could also do the trick. But the problem is with the kidney. There's nothing wrong with the production of ADH. ADH levels will be normal, or maybe even a little elevated. Clinical presentation of these patients, the same. Polyuria, nocturia, polydipsia, normal natremia, maybe a slight hypernatremia, as long as the thirst centers are working okay in the brain. What's the cause of nephrogenic diabetes insipidus? One of the big causes is people who are bipolar or the other psychological disorders who are being treated by lithium. The lithium seems to soak into the principal cells and mess up the production of the all-important aquaporins 2 channel. Remember, aquaporins 2 channel is on the luminar surface of the principal cell, and that's the only way water can get out of the filtrate into your principal cell, and then it goes into the interstitium through type 3 and 4 aquaporins channels, which are always there. They don't have to be made, but these guys have to be made, and they have to be inserted into the luminal membrane. Okay. The lithium therapy, again, we said bipolar or manic depression is yeah. Actually, aren't those AKAs? I think nowadays. But anyway, either one of those if you see those on a test. All right, and look at this number. About a third of the patients who are on lithium therapy, they actually have a touch of diabetes insipidus, so it's a very common problem with them. Another cause is poorly controlled diabetes mellitus. So somebody has diabetes, it's a silent killer, right? You don't feel any, you feel fine, but you have too much sugar in your blood, and that sugar can cause trouble. In fact, it looks like it somehow blocks the implantation of aquaporins 2 channels into the luminal surface of the principal cells. So there's nothing wrong with the making of aquaporins 2. It just can't be inserted. So diabetes mellitus again affects aquaporins 2 channels. And we said lithium therapy also fears with the production, actually the making of aquaporins 2. So if you don't remember that, I think I took this out this quarter because you guys are probably so good with this. But remember, here's a principal cell which we've already studied, and ADH binds to the V2 receptor, and it stimulates through the central dogma the creation of these aquaporins 2 channels here in purple. And then they're implanted in the luminal surface of the principal cell. And because the water is there's so many water molecules out here, the water will, even in a normal person, the water will shoot right through here, fill up the cell, and then it goes out through aquaporins 3 and 4 channels here in dark green, which are always in place. And just to finish off this little discussion, remember when ADH releases from the V2 receptor, these, by mechanisms we won't worry about, these receptors, or these little globules right here, these little vesicles, will go and pick up the aquaporins 2 channels and go back to floating around the cytosol, waiting for an order to go put them back down again. So aquaporins 2 is not there all the time. Aquaporins 3 and 4, it's there all the time. Gene mutations is another cause of this. Won't get into the specifics of that. But the genes that make the V2 receptors, the genes that make aquaporins 2, and there's certain regulatory proteins we won't get into, so you can have mutations in those genes, which can come on from radiation. They could be born with it. There's a lot of different causes of that. All right, this one I almost left out, but let's talk about it. This is called Dipsogenic diabetes insipidus, or primary polydipsia. Very rare. Goodman doesn't even talk about it, which is a pretty famous endocrinology book. James does, so let's just mention it then. It occurs from drinking too much water. These patients don't have polydipsia, they have hyperdipsia. That's like crazy. That's pathologically drinking too much water. Okay, and so they're going to have the same symptoms: polyuria, nocturia, hypertonic urine, the whole 9 yards, just like the others. What's the cause? We don't know the cause. These people with schizophrenia, very common for them to overdrink water. Almost a quarter of schizophrenic patients drink water just habitually. Some research shows it could be a tumor in the thirst center of the hypothalamus that doesn't work right and makes you thirsty all the time. And yeah, the symptoms are the same. All right, how do you treat diabetes insipidus? Well, the one you should know is this desmopressin, DD-AVP, super potent antidiuretic, or you could call it a 8-DH agonist. What's the difference between agonist and antagonist? An agonist is going to put the cell in agony and make it do something. An antagonist is going to block its function. Or we could call it a pressor agent. Pressor agent. Okay, what does it do? So it binds, this desmopressin will bind to the V2 receptors, just like ADH. Only it super stimulates them way more than normal, makes them very excited. And therefore they really crank out aquaporin's 2 channels. It's got twice the potency of normal ADH. It doesn't work well, however, in patients with mutated V2 receptors because it can't bind, and it doesn't work well in patients with mutated aquaporin's 2 channels, right? Because that's its mechanism. But any other type of diabetes insipidus, I did ask that question last time and about 10% got it right, so watch out for that question. The number one complication of desmopressin is you allow too much water to come in. There's too much reabsorption. And so you get a dilution, hyponatremia, which means there's too many water molecules and not enough sodium molecules. Right? Then, of course, if you reabsorb too much water, you'll get hypertension. You can get headaches and seizures, depending on how high the hypertension gets. All right. Let's talk about SIADH, the syndrome of inappropriate secretion of antidiuretic hormone. SIADH. And it occurs from an oversecretion of ADH. Maybe the magnocellular neurons are hyperactive or inflamed and spitting out too much ADH. Sometimes there's nothing wrong with the magnocellular neurons. Sometimes it's a tumor, like a lung cancerous tumor, that just happens to secrete ADH without regulation. So it could be from an ectopic source, or it could be from ectopia. And we've talked about that. So how are these patients going to present? Well, if you oversecrete ADH, you're going to absorb too much free water. So you could have a hypertension. That's not the big one. They don't quite understand why the hypertension isn't higher in these people. But what is the problem, I should have put this first, is a hyponatremia. Too much water molecules versus salt molecules in the blood. So you have a hypoosmolalic blood, right? Or you could say hyponatremia. They're basically AKAs. There's some subtle differences for your purposes. They're AKAs. There's 4 different types of this. We're not going to get into that. We'll just talk about the most common form. And yeah, it causes hyponatremia. In fact, Jameson and Williams agree that the most common cause of hyponatremia in the body, or in a human, is this SIADH. And it's the cause in about 1/3 of the patients who are diagnosed with hyponatremia. So that's the hallmark of SIADH. Okay. And yeah, it can quickly become fatal, as we'll see. There is a congenital, well, there's 2 types. There's an acquired, which is by far the most common. There is a hereditary SIADH, and this has been in the news if you pay attention to the news. Gain of function mutations. There's Dr. Fauci's in some controversy or hot water maybe about doing gain of function research to make viruses better. Maybe coronavirus is better. We don't get into politics here, but that you might have heard gain of function in the news. That means that whatever it's talking to has gotten stronger, it's gotten better, gotten better at doing its job. And so you can get gain of function mutations with the V2 receptor, which make them very successful at binding ADH. Normally the ADH, those V2 receptors, they don't bind all of ADH, maybe 85, maybe 90%, but a gain of function mutation binds 100% of ADH. So that's going to drive the reabsorption of free water. It's going to make that increase because of that. Okay, so you get too many aquaporins 2 channels if you bind too much ADH and too much water in the blood. Right? And there's your hyponatremia. Now the acquired causes, the central nervous system diseases can definitely do it, like a stroke could do the trick, and all these conditions can stimulate the over-releasing of ADH. So a stroke, a subarachnoid hemorrhage, some infections can do it. Then, as we said, ectopic release of ADH, like cancers. I always put this on the test, and about half of you will miss it, but SIADH can come from small cell carcinoma. In fact, it's not uncommon for this type of cancer to release ADH ectopically on top of your normal ADH production. Okay, let's take a look at this. 41-year-old male with complaints of headache, neck pain, and back pain comes in. Long history of chronic cough, 20 pack year smoker. Blood pressure was slightly elevated, 140. That's barely hypertension according to most of the board books. Remember, the board books haven't adopted those complicated guidelines. Anything over 90 over 140. If you hit 90, if you hit 140, either one of those you have hypertension. The patient's barely got hypertension. But here's the key. His blood work does show a moderate to even severe hyponatremia. So you're thinking, ADH. What's the deal with that? Too much ADH. SIADH maybe. You take an x-ray of his lung. He's a 20-pack year smoker. He's a heavy smoker. And what do you see? I'll give you a minute. You see it? Let me help you. That's the aortic knob. That's the aortic arch right there that forms the aortic knob. Well, if that's the aortic knob, what in the heck is that? And that is a big, nasty tumor, of course. And that was small cell carcinoma, and it did secrete ADH. Okay, some more causes of SIADH. You can have drug-related causes. Look at this surprising one. SSRIs, millions of people are on those things. Zoloft and Prozac and Paxil. Anti-seizure medications, antipsychotics, ecstasy, popular recreational drug, MDMA, not to be confused with NDMA, which is the one that is in some H2 blockers that was recalled because of cancer, the cancer causing NDMA. This is MDMA. Don't get those confused. But that can do it as well. It triggers the release of ADH. It stimulates the brain in some good ways, in some ways that aren't good. You don't want to over-secrete ADH. Desmopressin, which is used also to treat von Willebrand factor, can do it. Actually, that's right, because that's the treatment for diabetes insipidus. So maybe they're old and they're taking too much of that. All right, what's the clinical presentation of someone with SIADH? Well, you do a urine analysis, and if they're reabsorbing too much free water, how's the urine going to be? Too wet or too salty? It's going to be too salty. There's too many water molecules taken out. So you have a hypoosmolaric or hypoosmolar urine. I guess the adjective should be used, hyperosmolalic urine. Or you could say a hypertonic urine. You could say a salty urine. Boards aren't going to say salty, but that's what it is. Okay, we don't have to worry about those numbers. And in fact, this is a requirement for the diagnosis of SIADH, is to have a hypertonic urine, salty urine. Blood work will find hyponatremia because of all the extra water molecules poisoning the blood. I shouldn't say poisoning, but just bombarding the blood makes sodium scarce. They may have a mild hypertension again, they may not. It's confusing why they wouldn't have more of a hypertension, but they don't. A differential diagnosis. Now we need to talk about this. And oh no, there's the guy we saw back in embryology, right? You didn't like that little guy, that little nerdy guy when he popped up, because we're going to get a little deep here. But Addison's disease is a differential diagnosis because that can also cause hyponatremia. How does it cause hyponatremia? Well, Addison's disease means that the adrenal gland is upset and it's not releasing cortisol or aldosterone, and sometimes not even the adrenal, or not even ADH, which is not really clinically important. But that's not good if you're not releasing aldosterone. Well, you're not reabsorbing salt or water. But then I hear you saying, well, that would cause hypotension, but that's not going to, if it reabsorbs salt and water, how is it going to cause hyponatremia? How is it going to cause a sodium poor water? Well, it doesn't. It's kind of a lopsided withdrawal, as we said. And it does suck more, aldosterone sucks more sodium out than water. So it does by itself cause hyponatremia. But normally the hypotension stimulates turns on to the R2A system. And that causes the production of angiotensin 2, and angiotensin 2 can bind to ADH and cause it to reabsorb free water to kind of negate this effect here. But in this case, there's not going to be hypotension, as we said. So angiotensin 2 is not going to be around to offset this lopsided reabsorption of salt and water. And so too much salt is going to be taken out. You're going to get hyponatremia. All right, if that makes sense. There's part 2 anew. And there's another part of the story here, because we said that cortisol is not released. So you have hypercortisolemia in patients with Addison's disease as well. And so normally what shuts off ADH? Normally it's high levels of cortisol. So magnocellular neurons have nothing to turn them off. And so that's also going to drive the hyponatremia. Okay. Symptoms of SIADH. Well, hyponatremic symptoms. And those are all neurologically basically. So neurologic symptoms, we'll look at those, I think, in a second here. And again, the water uptake's not bad enough to cause really a bad hypertension, so don't rely on that. Neurological symptoms can get severe, and that has a word as well. It's called hyponatremic encephalopathy. Hyponatremic, not enough salt. And where's the body going to get the salt from? It's going to suck the salt out of the brain cells again, and that's not good either. It causes dysfunction of the brain cells and kills the brain cells. And so you get a headache, lethargy, weakness, vomiting, confusion, weird neurological deficit, seizure, and coma. So, same kind of story. How do you treat this one? Well, if they have too much water in their blood, you certainly don't want them drinking water, so you put them on a water restriction. So they don't get any more than 1 liter per day. And then it's very common for them, if they need more salt in their blood, give them salt tablets or give them an infusion of salt. And that's a quick way to get more salt in the blood. This is always confusing. About 10% of people usually get this question right. So glucocorticoid replacement therapy is another important treatment for SIADH. Now, how in the world can giving someone glucocorticoids affect this whole story? Well, if you give them high levels of glucocorticoids, if you put a lot of cortisol, so glucocorticoids, that's cortisol therapy, right? You're basically giving them cortisol. So the cortisol then will go bind to the magnocellular neurons and shut them down. Well, if they're shut down, they're not going to be over-releasing ADH as much, or maybe not at all. So that's a way to shut it down with glucocorticoids. Although then you have the problem of having too much cortisol around, and you can start to get Cushing symptoms, which we'll talk about probably next week. We could also go after the V2 receptors that bind the ADH. If we block some of them, then ADH won't have much of an effect. So that will decrease the free water uptake and kind of even things out more. All right, that's enough for your brains. That was there's a lot of material. That's a tough lecture, so I'll play it back. Email me those questions if you have questions. And I'm going to rest my voice for a while, and a couple hours I'll do the CVPP lecture that we need. All right, see y'all later.